Our next speaker is Dr. Maria Gabriela Kuba. She's one of our young pathologists, so I will start from her residency. She did her residency at Vanderbilt University and did her surgical pathology and breast pathology fellowship at the Brigham. And she just joined us at our breast team just a year and 3 months ago. So she will give the second case.
Thank you. So the patient is a 63-year-old female who presented in February last year with a 2-centimeter red pale skin lesion on the left breast. She had a prior history of invasive carcinoma on the same breast 25 years prior, which was treated with conservative surgery and adjuvant chemoradiation. Then in December 2012, she presented with 2 red skin lesions on the same breast, which were clinically thought to be due to radiation dermatitis, and therefore she was followed up locally. Then in May 2013, she noticed skin changes in the area, and that was biopsy and subsequently excised with a diagnosis of atypical vascular lesion, which was MIG negative both by FISH and IHC. And then she did well until early 2018 when she presented with this lesion I just described. Physical exam, there were no associated masses, and a biopsy was performed given the concern for another vascular lesion. First, I'll show you I think that this was one of the slides that I submitted, the typical vascular lesion from 2013, where you can see on the dermis dermal fibrosis and chronic inflammation consistent with radiation changes. And also, more prominently on the right side, you can see many dilated and somewhat irregular vessels. On higher power, you can see that these vessels have sort of an angulated contour and dissect through the dermal collagen. These are lined by a single layer of endothelial cells, which are hyperchromatic but otherwise show no significant nuclear atypia. You can see somewhat an interanastomotic pattern of these vessels. So this was the atypical vascular lesion. On ERG, you can see that highlights these atypical vessels, and this was negative for MIG by IHC and FISH. Now, the biopsy from February 2018, on low power, it doesn't show any significant lesions. However, on higher power, you can see on the upper dermis a cluster of mildly dilated vessels with somewhat plump endothelial cells, which are highlighted on CD31 and ERG stains. You can see also that there's somewhat of a branching architecture of these vessels, and this lesion was MIG negative by IHC. And this was diagnosed as an atypical vascular proliferation. Now, given the clinical concern for this lesion and to rule out an angiosarcoma, an excision was recommended. However, the patient wanted to delay surgery because she mentioned she had a wedding in the summer. In the meantime, she underwent imaging, which was negative except for post-surgical changes on the left breast. And then she came back for excision in October. Grossly, there were no distinct lesions. However, we can see here on low power that there's a proliferation with a multinodular pattern, mainly confined to the dermis, composed of sheets of spindle cells, which show mild cytologic atypia with ovoid nuclei, small to inconspicuous nucleoli. There were rare mitosis seen, probably up to 4 per 10. And focally, this tumor had a basoformative pattern. At the edge of this tumor, there were areas that very much resembled the atypical vascular lesion from 2013 with these sort of angulated branching vessels. Now, ERG is positive in this tumor, and MIG, again, was negative both by FISH and IHC. So morphologically, this was consistent with the radiation-induced angiosarcoma. And morphologically, it's not a very challenging case. However, I always thought of MIG as the hallmark, MIG amplification as the hallmark of secondary angiosarcomas of the breast. And as I was working on this case, I was wondering how frequent are MIG-negative radiation-induced angiosarcomas of the breast, whether they have any different clinical pathologic features, and whether there are any other markers that can help distinguish between AVLs and angiosarcomas, given that sometimes MIG is used as a diagnostic tool to distinguish between these two, especially on biopsy specimens. And also, I was wondering if the prior AVL had progressed to the current tumor. So first, I'll do a brief review of post-radiation vascular lesions of the breast. AVLs usually present in patients in their 50s, which are younger than those diagnosed with angiosarcoma. The risk is unknown, given that the incidence is not very well documented, where angiosarcomas develop in 1 to 3 per 1,000 patients treated with radiation therapy. Usually, AVLs arise 3 years after completion of radiation therapy, whereas angiosarcoma 5 to 10 years later. AVLs are confined to the skin, whereas angiosarcomas can also involve the chest wall and the breast parenchyma. Clinically, AVLs present as very small lesions, usually sub-centimeter lesions presented as single or multiple pink papules, whereas angiosarcomas are usually a few centimeters large, presenting as erythema, sometimes described as bruising. They can have associated palpable masses, and they can diffusely involve the breast. AVLs are benign lesions, which can recur but have no metastatic potential, and these are usually treated with complete excision, basically to rule out a well-differentiated angiosarcoma or an unsampled angiosarcoma. In contrast, angiosarcomas have a very poor prognosis with a 5-year overall survival of approximately 50%. Most of these patients usually undergo mastectomy, with a subset of them also having adjuvant chemotherapy or radiation therapy. And this is a typical example of the clinical presentation of AVL. In this case, the patient had multiple. You can see these small pink papules. Histologically, these are well-circumscribed lesions, usually confined to the dermis or upper dermis. You can see here a proliferation of dilated vessels with a somewhat interanastomosing pattern, lined by a single layer of hyperchromatic endothelial cells, but otherwise no significant pleomorphism. These lesions are sometimes described to have like a wedge-shaped pattern, and they can have a hobnail appearance to the vessel. So you can see here the nuclei of the vessel somewhat protruding into the lumen. They can also dissect into the dermal collagen, kind of somewhat of an infiltrated pattern. But again, these are lined by a single layer with no endothelial multilayering and no mitosis. In contrast, angiosarcomas are clinically more worrisome lesions. This is a patient who presented with a recurrent angiosarcoma at the site of the prior mastectomy scar, and you can see these 2 large purple nodules. This is the patient's excision, where you can see these 2 nodules, one of them ulcerated. And this tumor has a multinodular growth pattern, which is very typical for angiosarcomas, and also on low power, you can appreciate all these blood lakes. The tumor had predominantly a solid growth pattern composed of these sheets of pleomorphic or very atypical spindle cells with a focally vasoformative pattern. And on higher power, you can appreciate the nuclear pleomorphism with vesicular chromatin, prominent nucleoli, and numerous mitosis. Angiosarcoma can also have an epithelioid morphology, which can be somewhat tricky. In this case, you can see these nests of polygonal to round cells, but again, an ERG would be positive in this case. This is a patient who presented last year with these lesions. So she had a history in 2013 of invasive ductal carcinoma on the same breast. In 2016, she was diagnosed on the same breast with an angiosarcoma, and now she presented with skin discoloration in several areas of the breast. Which were worrisome for a vascular lesion, right? An initial biopsy was non-diagnostic, and therefore she underwent an incisional biopsy, which you can see here, where there's a tumor, a hemorrhagic tumor, involving from the dermis into the subcutaneous tissue and focally involving the breast. Histologically, you can see that the tumor has a multinodular growth pattern extending from the dermis into the subcutaneous tissue, and also focally here involving the breast, composed of sheets of spindle cells with focally vascular channel formation. So this is angiosarcoma. Now remember that this patient had a prior history of invasive ductal carcinoma. So we have here also in the same specimen some areas with these nests of epithelioid cells with somewhat of a suggestion of a lumen here and there, or a gland. And higher power, you can see that these cells are very pleomorphic, vesicular nuclei, prominent nucleoli. However, on ERG stain, these are positive, consistent with an epithelial morphology of the angiosarcoma, which can be a pitfall if we have a very limited biopsy with no clinical history or no description of the targeted lesion. So to summarize, atypical vascular lesions, histologically there is a well-circumscribed lesions, whereas angiosarcomas can be diffuse or multinodular. AVLs are usually confined to the dermis, whereas angiosarcomas can also infiltrate into the subcutaneous tissue and the breast parenchyma. Blood lakes, endothelial multilayering, papillary endothelial hyperplasia are only seen in angiosarcomas. Cytologically, AVLs show mild nuclear atypia, and usually we don't find any mitosis, whereas the pleomorphism in angiosarcomas is usually more prominent. Mitosis are usually frequently seen, but they may be rare as in our patient. Now, it is important to keep in mind some common morphologic features, such as both lesions can show anastomotic dilated vessels, we saw in the examples. They can have dissection of the dermal collagen, and they can show nuclear hyperchromasia. Now, this is a list of the studies looking at MYC amplification in post-radiation vascular lesions of the breast. And to summarize, what they found is that MYC is amplified in the majority of radiation-induced angiosarcomas and in none of the atypical vascular lesions. They also found that there's excellent concordance between IHC and FISH, concluding that IHC is a good surrogate for MYC amplification. Now, what about this subset of MYC-negative cases? There's very limited data, and this first study from 2010, which is actually the first study that described MYC amplification in secondary angiosarcomas, they had 33 secondary angiosarcomas, 20 of which were post-radiation angiosarcomas of the breast. And they found no difference in grade between amplified and non-amplified tumors. A more recent study from 2015, they included 37 radiation-induced angiosarcomas, 17 of which were non-amplified. They found no difference in morphology, tumor grade, or size. However, those patients with MYC-negative tumor appeared to have longer overall survival. Now, with this information, we decided with Cristina Antonescu and Binzu to look at our experience with MYC-negative angiosarcomas in our patient population. So we looked for cases of angiosarcomas diagnosed between 1998 and August this year. We included only patients that were previously treated with radiation for breast cancer, and also only cases that had MYC status available either by FISH or MSK impact. We had 81 women. The median age at diagnosis was 69, and the latency was 7.5 years. Clinically, about 2/3 of the patients presented either with skin discoloration with or without skin thickening. A third of them presented with papule masses. One patient presented with small papules, but at the time of the biopsy, that apparently they rapidly grew. And then 2 patients, the tumors were detected on screening. The majority of patients underwent mastectomy. 8 of them had wide local excision, and 2 patients did not undergo surgery, given that they had extensive local disease diagnosis. So overall, we found that most of the cases, the vast majority, 97% of them, had high-grade morphology. Epithelioid differentiation was seen in 12 cases. More than 2/3 of cases were 5 centimeters or smaller, and then 7 cases had positive margins at initial surgery. We found overall that 8 cases were MYC negative or non-amplified, 10% of our cohort. We found no differences in the clinical pathologic features except for tumor grade, where we found there were 2 low-grade tumors that were only seen in the MYC non-amplified group. And this is one of them. This is one of the low-grade, morphologically low-grade angiosarcomas. That was a fairly young patient presenting at age 48 with a history of breast cancer 5 years prior, who presented with multiple palpable nodules at presentation. This is her mastectomy specimen, where you can see a tumor composed of dilated vessels infiltrating the breast parenchyma and also focally the adjacent fat. It is distorting the lobules, and you can see this interanastomosing pattern of the vessels. Focally, you can see also some blood legs on the top. And these tumors have mild cytologic atypia with actually very rare or no mitosis seen in this tumor. So this was a low-grade angiosarcoma, which can be a pitfall if we have limited material. We had the median follow-up for our cases was 22 months. The 5-year overall survival for a group of 51%. 54% of patients developed local recurrences, and 1/3 of them distant metastases. Now, on outcome analysis, patients with positive margins at initial surgery and those that had MYC-amplified tumors had worse overall survival. We found no correlation between age, tumor grade, size, epithelial differentiation, whether the patient received chemotherapy or adjuvant radiation, and outcome. And on multivariate analysis, we found that positive margin was the only independent adverse prognostic factor. So in our cohort, we found that 10% of angiosarcomas lack MYC amplification, and that this group can show low-grade morphology. We confirmed previous finding that they have an overall poor prognosis, and found that positive margins and MYC amplification appear to have a prognostic significance. Now, what about other markers that can be used to distinguish between AVL and angiosarcomas? Well, this study from last year, they looked at H3K27Me3 expression in radiation-induced vascular lesions of the breast. So loss of trimethylation of histone H3 is an epigenetic event that has been described in several tumors, including MPNST, And the majority of radiation-induced MPNSTs have shown loss of this marker as compared to sporadic or NF1-associated tumors. So the authors looked at expression of this marker in benign, atypical, and malignant radiation-associated vascular lesions in the breast. So this is an example of how this marker the expression of this marker. This is a radiation-induced MPNST, and you can see the tumor that has loss of expression, whereas the normal control, you can see retained expression in the normal epithelium, or I think it may be this. And what they found was that loss of expression, which was defined as 0 to 25% nuclear expression in the tumor, was only seen in angiosarcomas. None of the controls or the atypical vascular lesions show a loss of expression. And this is some pictures from their paper. It's a red chromogen, so it may not be easily seen. But you can see that the typical vascular lesions show retained expression in the endothelial cells, whereas the angiosarcoma, better seen on the lower right picture, you can see loss of expression in the tumor cells with retained expression in the adjacent normal control. Now I ran the antibody in my case just to see, but it's diffusely positive, so this would not have helped on the biopsy. Now, other genetic alterations besides MYC amplification that have been described in secondary angiosarcomas involve genes related to vasculogenesis. KDR is a tyrosine kinase receptor. Mutations in this gene have been described in both primary and secondary angiosarcomas, and this is a promising target because it has shown tumor growth inhibition by in vitro. Now, for amplification, it's only seen in MYC amplified tumors, and this correlates with poor prognosis. However, this is an actionable target. Now, as I mentioned before, prognosis for radiation-induced angiosarcomas is very poor. Regarding prognostic factors, tumor grade or differentiations has shown to have no effect on that. In one study, patients older than 68 tend to do worse. Patients that had radical surgery apparently have better outcome. And the role of tumor size and margin status is still controversial with different results. In contrast, atypical vascular lesions usually follow a benign clinical course. Again, these lesions, up to 20% of these lesions can recur, but they have no metastatic potential, and there are very rare reported cases of progression to angiosarcoma. Today, there are 7 cases reported of progression. Most of them have a latency from completion of radiation therapy to presentation of the AVL of about 5 years. However, if you focus on the second case, where the patient presented with an AVL 9 years after breast cancer with a hematoma, and then a few months later, he was diagnosed with an angiosarcoma, it's questionable as to whether the original AVL was actually an unsampled angiosarcoma. Now, on other cases in which we have at least a couple of years latency between the AVL and the angiosarcoma, we can see that the clinical presentation of the AVL usually was like a small papule or a small nodule, and then the subsequent angiosarcoma as a more worrisome lesion, like papillary mass or diffuse involvement of the breast. Morphologically, these tumors range from low grade to high grade with epithelial morphology, and of note, 2 of these cases were MYC negative. On follow-up, which was available for 4 patients, 4 of them were alive at a median follow-up of 40 months. So what about our case? Did the atypical vascular lesion from 2013 progress to the current angiosarcoma? Well, if we go back to the clinical history, we have these nice diagrams from the surgeon, where you can see that the current angiosarcoma developed at the same area as the atypical vascular lesion from 2013. So in fact, it developed in the same area, in the area of the incision of the prior AVL. We also have the fact that both lesions are MYC negative, so that's sort of like on one side. On the other hand, we know that AVL and angiosarcomas arise in the same area of the radiation field. We know that AVLs follow a benign clinical course, and we also have no evidence of clonal relatedness between these 2 lesions. So it is unclear if these lesions are actually related or not. Now, to summarize, we've seen that AVLs and angiosarcomas can show significant morphologic overlap on biopsy. Therefore, clinical presentation is very important. And sometimes excision may be necessary to reach a definitive diagnosis. AVLs are usually small, circumscribed, usually confined to the dermis, whereas angiosarcomas have a more diffuse multinodular infiltrative growth pattern. And if you have solid growth, that would be a better clue. Angiosarcomas is MYC amplified in the majority of cases. However, there's a subset of MYC negative cases which can show low-grade morphology, and they appear to have better prognosis, but this is based on the limited number of cases. H3K27ME3 may help distinguish between AVL and angiosarcomas. We've seen that AVL has are benign versus, whereas angiosarcomas have a very poor prognosis. There are very rare cases of progression to angiosarcomas, and therefore continuous surveillance and biopsy of suspicious lesions is necessary. And that's all. Thank you.
Any questions? Anyone? I think this is a really diagnostic challenge for all of us, especially infiltrating looking AVLs. And so you said, are they doing MSK impact on, not that it is yield anything in AVLs, but
Some of them have.
and is there any, do they even find any mutations in AVLs? Do you know?
Oh, no, not in AVLs. No, I haven't seen any in AVLs.
So if you're looking for clonality, something like that, but AVLs are such low cellular lesions, the yield is going to be tough. But